Good evening, everyone. I, Dr. Ashita Punjabi Hakku, on behalf of IFS MP chapter, along with SIG on genital tuberculosis, welcome you all to yet another enlightening session on our series on genital tuberculosis. So today's topic is treatment of genital TB, what every gynecologist must know. And today we have with us Dr. Vishwas Gupta, sir. Can I have the CV, please? Dr. Vishwas Gupta, sir, is MBBS, DNB respiratory disease. Currently, he is working as assistant professor in the Department of Respiratory Medicine, Gandhi Medical College, Bhopal. Sir has done his graduation MBBS from MGM Medical College, Indore, and his DNB is from Leela Padvati Hospital and Research Center, Mumbai. Sir has a vast experience in his field and he has more than 15 publications in national and international journals. We welcome you, sir, to this session, and I hope this class will help us have a knowledge increased in the field of reproductive medicine while dealing with the cases of genital TB. Over to you, sir.
Thanks a lot, ma'am, for your wonderful introduction. Okay, so we'll start with menstrual tuberculosis elimination program. The name has been changed. I know most of you know the name RNTCP, which was the previous name. We want to just eliminate the TB. We want to just control the TB in that program. Now we changed our motive to from the control. Now we want to eliminate the TB from India. The target is 2025. I know it's very difficult to achieve this, but at least we should try for it. So today I will be on the side of the government and I will advertise this program to you. I'll tell you what is the benefits of this program, what this program will provide to you, what you can expect with this program. Actually, what is the benefit to attach with the program so that you can easily treat your patients. So this whole session will be only clinical. There's no theory I'll teach you because you people know better than me how to be progress in the genital area and in a female genital tract. But I will teach you just only the things which are actually you need clinical. So without wasting time, start it. What actually NTP program wants from a clinician, from any clinician actually, especially a surgeon. So whatever your sample, just get it and send it to the lab. So what is the meaning of this? If you are doing any surgery, even if you are not suspecting this is a tuberculosis, just get the sample and send to the for the tuberculosis process also. Why I am saying so? Because program actually provides you lots of lab investigation, which are actually free for the patients. Second, and if you are not getting any diagnosis, most of the time it happens, you are thinking something else, you're thinking for malignancy, it turns out to become a TB. So that time you will not be in dilemma, it is TB or it is not TB, because histopathology alone cannot make a diagnosis. I'll tell you how. So whatever the sample, if you are getting a tissue, send it. If you are getting a fluid, send it. If you are getting urine, plus minus, I'll tell you later why urine. Menstrual blood, that you can also send, but for few investigations only. And if you get anything else, just get these samples and collect it.
Excuse me, sir, your slides are not visible. You have to share screen.
Okay. I'm not sure. Now?
Yes, sir, it's visible now.
Okay. So whatever sample you are getting, just get it. If you are getting a tissue, fluid, urine, blood, etc., whatever you get, just collect in a normal saline bottle. Remember one thing, whatever sample you are collecting for any microbiological test. I'm not asking only for tuberculosis. If you are suspecting any aerobic culture, bacterial infection, you want to send it for aerobic culture, do not collect these samples in formalin. Only collect either if it is a fluid, directly collect in a sterile container, or if it is a tissue, collect in a normal saline, preserved in a normal saline. And these samples you can send for these investigations. So we'll discuss these investigations one by one. First and foremost is CBNAT. CBNAT is a generic term used by this program. Gene Expert is the name of a machine. Most of the private labs use this name Gene Expert. One of the same thing, CBNATs and Gene Expert. Culture. Culture you have, whatever culture you have read in your MBBS time, that solid culture and liquid culture, these are the same culture. Culture is still a gold standard test to diagnose TB. CBNAT and Gene Expert are the new tests which are based on PCR. Now culture is a gold standard test. Others like LPA. LPA is also a test which is based on PCR. Little bit different from Gene Expert and CBNAT. I will tell you what the difference. And if you are collecting a sample for histopathology, collect in a formalin. So remember this point because this is very important. If you collect in a wrong bottle, if you collect a sample directly in a formalin, all the bacteria will die. No machine, not a culture, CBNAT, no machine will detect these bacteria. So this is the first and foremost point. Whatever surgery you are doing, whatever sample you are collecting, collect in a normal saline and send lab for any of these investigations. Especially Gene Expert or CBNAT because it's used in diagnosis. So a little bit about CBNAT. CBNAT actually cannot perform in blood, stool, or urine. Why? Because in previous slide, I told you the blood. So blood and urine are in bracket. That's why, because these samples cannot, in CBNAT, we cannot perform, CBNAT cannot be performing urine and menstrual blood. Why? Because blood has some components which are inhibitory to PCR. And these tests are PCR based. So you cannot send sample for CBNAT. So if we are talking a clinical point, you are taking a sample, getting a sample, send it for CBNAT. Why? Because CBNAT is turnaround time is of CBNAT is only 3 hours. That means a result will come to the next day. If lab is so equipped, they can give you result next day, or if it is a busy lab, next day you will get your results. What result you will get after CBNAT? First is MTB detected or not detected. That means there is a TB there. If this machine finds that there is a live TB any live or dead TB bacilli which is present or not, that means MTB detected or not detected. Second result it will give you whether this sample is rifampicin sensitive or resistance. So 2 results you will get simultaneously in a day or two. First is MTB detected or not, because now if it is MTB detected, that means your sample is confirmed TB. Look, there are 3 types of diagnosis of tuberculosis. First and most strong evidence is microbiologically confirmed. Microbiologically confirmed means either you have seen this bacteria on smear, CBNAT, or culture. Any of the microbiological investigation getting the bacteria, that is the most strong evidence of a disease. So that's why if your CBNAT is positive for Mycobacterium tuberculosis, this sample is confirmed for TB, you can go ahead with the treatment. Secondly, it will also tell you about the resistance pattern for the rifampicin. If it is rifampicin resistance, that patient turn around to become a MDR2. So that you now have to send to a nodal center for this treatment. So whatever. So if you are getting a sample, send it for CBNAT at least. Most of the government, what NTP can do for you, whatever sample you are sending, this lab will automatically run culture for the same sample. And what is the disadvantage of culture? Culture takes 2 months to come. Results to come, it takes 2 months. So if you are sending a sample today, you will get the culture after 2 months. So it is a long delay. CBNAT comes in a day or two, and CBNAT comes after 2 months. So automatically they perform culture on the same sample, so that whatever result will come, but you will get in after 2 months. So if you are getting blood or urine, and urine, you forget about urine. So if you are getting a blood in your samples, menstrual blood or something, you can send it for culture only. You cannot perform CBNAT in blood. Okay. So am I clear about the CBNAT and the sample? because this slide is actually very important in this whole lecture. So if there are any doubt, you can ask her only. Okay, so now I'm continuing. These are the diagnostic tools available. These are the whole battery of investigation which are available. I'll tell you one by one what are these tests. Smear microscopy is actually for most of the time sputums, extrapulmonary sample. We don't perform by microscopy, but you can. But the sensitivity will be very. Sivinat, I already told you, it's a PCR-based technology, highly sensitive, almost equivalent to the culture. Almost equivalent, I am telling you, not equivalent to the culture. Why? Because the sensitivity in extrapulmonary samples drops down to 70%, or sometimes even 25%. Which is very difficult to get the Sivinat sample positive in extrapulmonary samples, especially in endometrial tissues, because actually it is shedding very frequently. Other tissues, if I am talking about any surgical issues like abdominal TB or pot spine something, the results are look little bit better than a gynecological sample. But definitely, culture is available. You can send it. There's no supportive test. Definitely, if you are suspecting a case which can be TB, you are differential diagnosis tuberculosis, ask for a chest X-ray. Why? Because the entry point for any bacteria is lungs only. Ask for a chest X-ray. Tuberculin sensitive tests, that means Montauk's and IGRA. I know most of the people actually confused what should be done with a positive Montauk's or a positive IGRA. I'll tell you. Look, these tests are basically tell about the latent infection of the TB. It doesn't tell about the active infection for the TB. So never ever make your diagnosis based on the Montauk's or IGRA. Remember my point, never ever make your diagnosis based on only on Montauk's or IGRA. If you have strong clinical suspicion that this is a tuberculosis case, you can go with the treatment. But if your decision should not be based on the IGRA. IGRA will come positive for the 70% of the Indian population. Same as the Montauk's test, because we are living in an endemic country, and this country is lots of tuberculosis patients, and we people sitting in a OPD, seeing lots of patients coughing in on just in the vicinity of us. So we can most of the doctors actually exposed with the bacteria in their day-to-day life, and these exposure with the bacteria can cause the positive Montauk's test or positive IGRA test. So we should not take ITT on a regular basis because we are IGRA positive. Same with the patients. If it is IGRA positive or Montauk's positive, do not start treatment based on these tests only. You can use these tools as a supportive one, but should not be reliable for the diagnosis only. Cytology and histopathology. Definitely, this is actually the common thing which most of the gynecologists send these investigations, cytology or histopathology, and you get the result with a granuloma, and this becomes a suspicious for the TB. Why it is a supportive test only? Because in India we think every granuloma is TB, but if you see a reports of a person who is living in Europe, you should think for a fungal infection first, or sarcoidosis, or something else which can cause granuloma. Because 90% of granulomas are because of the TB, and 10% granulomas can be because of something else. So this histopathology is only a supportive test, but definitely if Sivinat comes negative, culture takes 2 months, so you can start your treatment on the basis of the histopathology. And definitely drug susceptibility testing done by culture, Sivinat, and LP is one of the tests. LP is same like Sivinat, but the sensitivity is little low than Sivinat. So after culture, lab people perform an LPA test, which can also gives you a confirmed diagnosis that TB is present. And secondly, it can gives results about the sensitivity of the rifampicin and isoniazid both. So it can also tell you about the MDR tuberculosis. So what are the benefits? What are the benefits of NTP? What programs provides you? First and foremost is diagnosis. Multiple microbiological tests, I already told you, all these tests are actually free in government labs. Just send your sample to any government lab, any government hospital nearby to your clinic, and they will perform any of the tests, whatever you asked for. Second, these labs, actually not all government labs, but some equipped lab, like I am actually practicing in Bhopal, Madhya Pradesh. So we have two good labs, government labs. One is IRL, one is NRL. These labs have the facility to process tissues. Are you getting my point? Because performing a tissue in culture or CBNAT is a little difficult. People have to crush this tissue with some equipments, and then only they can perform CBNAT or culture. This facility is not available everywhere. But wherever you are practicing, most of the big cities have the facility of IRL at least, intermediate reference labs. You can send sample there directly, or you can send sample to your nearby medical college or some district hospital. So they will send sample to the area where these facilities are available, but this facility is definitely available most of the places. Notifications. Definitely, it's a infectious disease, notifiable disease. As per government, if you don't notify this disease, they can ask you for the fine of 50 lakhs rupees. So definitely, whenever you send the sample for the CBNAT, the patient will automatically get registered in government portal so that you will be medico-legally safe. Third, definitely medico-legal, because now the government is also a party with you for the taking care of the patients. So government is giving you the facility. Result will be available on app. There's an app called Nikshay, which is actually a government app, and these CBNAT, culture, LP results will available on this app. You can download, and you have to register with the help of your district tuberculosis officer wherever you are practicing. The DTO will make you an account on this app, and you can see your patient's result on your app. Availability of drugs, definitely. If whenever you start on the treatment for tuberculosis, these all drugs are available free of cost in all government facilities. Remote to remote village will get these drugs. And if you are writing some private medicine, most of the time actually it is difficult for a medical store person to make register and make all the details available on this in this portal for all these drugs. So because like, these drugs are actually in surveillance of government, so that's why most of the medical store don't keep these drugs. So it is little bit difficult to availability of the private drugs. So better to start dots because it is available everywhere. Patient follow-up. The government people will go to the patient's house and counsel them, and follow-up will be done by them only. There's no headache for you to follow up these patients. Counseling part is also available with the government facility. And contact tracing. If it is an infectious disease like a pulmonary patient, contact tracing of the family members will also be done by the government. You should not be worried about these things. And management of adverse drug reaction because of these drugs will also be done by the person who is sitting in the government hospital. He will take care of the adverse drug reactions. Yeah, somebody wants to ask something. So management of adverse reaction can be done by you only, or you also, and a person who is sitting in the government hospital, he will take care of the minor adverse reactions. And also the financial support to the patient. Patient will get 500 rupees per month to take these drugs and treatment. So this was the financial support to the patient. Government gives free of cost. So if we conclude our previous 2 or 3 slides, first and foremost diagnosis is your clinical. Because most of the time you will not get anything in histopathology, you will not get anything in CBNAT or culture. So first and foremost is clinical. What I want to say actually, if I want to say this patient is suffering from TB, I am right, government will follow your instructions, start the treatment. First and foremost, if you think this is TB, this is TB. Nobody can challenge your diagnosis, why you have started. If it was not TB, nobody can challenge you. If it is a TB, I think this is these symptoms are related with the TB. This is TB. I'm starting the treatment. These are perfectly fine. This is perfectly fine. These are perfectly correct. 100% government will start this treatment. Nobody can stop you to start the treatment of tuberculosis. Lesser than clinical, histopathology definitely will add your diagnosis. It's very good sensitive, but little bit low specific because 10% cases can be sarcoidosis or some fungal infection also you will get. But in India, you will definitely go with a granuloma, go with the TB. Microbiological, definitely it is very low sensitive but very high specific. If it is a microbiology confirmed, this is confirmed, this is TB. Now you are medico legally safe. You can start treatment. You can follow up better. And at the end, this is my favorite sentence, जिसका कोई नहीं होता उसका टीबी होता है. If you think you are not getting any diagnosis, just start with the treatment blindly. My some gynecological friends send me patients because the lesion, one of my senior actually sent me a patient which is actually post LSCS wound, which was not healing with antibiotics. 2-3 months has been already passed. Nothing comes in culture. We started empirical treatment with ATT, and she responds well within 6 months. And after 9 months, we have stopped her treatment. Now she is completely fine. And there are not many cases actually we have started directly without any without any evidence, because we have treated with the antibiotics, not healing the lesion, healing is not improving, the lesion is not improving. Start directly with the treatment. So this is a comparison of mycobacterial culture in histopathological examination. You can see the culture is in the second slide. You can see this is the second column. You can see the culture is not always positive, but the histopathology is better than performing than culture. You can directly start with the treatment based on the histopathology or your clinical record. So what are the histopathological findings which are important? Chronic inflammatory cells, any type of chronic inflammatory cells like lymphocytes, giant cells, epithelioid cells, granuloma, caseation. Caseation is very specific term used most of the time in TB. So if you find a caseation inside the granuloma in your report, if pathologist says that there is a caseation inside the granuloma, that is confirmed TB, because this is very specific for the TB. Lymphocyte predominance, because this is a chronic infection. Langerhans giant cells, epithelioid cells, these all terms you can use for the TB. Otherwise, these are this is the histopathology, progression, inflammatory cell, proliferative endothelium, negative endometrial biopsy does not rule out the pelvic involvement, but definitely if you are suspecting a clinical scenario of a TB endometritis, you can go with it. What are the pre-treatment evaluation you need before starting the treatments? Chest X-ray, definitely, because this is the entry point. HIV you have to do in every patient, because there's a collaboration between NACO and TEP. There's every HIV patient will be sent for the CBNAT testing, and every TB patient will be sent for the HIV testing. So HIV testing is mandatory. Sugar is also important. Diabetes is also a important comorbidity in tuberculosis, developing tuberculosis. This is a very important immunosuppressed status. So definitely go for any sugar testing, HbA1c, FBS, RBS, PBS, whatever you want. Just rule out diagnosis for diabetes also. Important thing, what you should not expect with the treatment. First and foremost is it is not an antifibrotic. What it does mean? In Asherman syndromes, if patient already developed fibrosis, ATT will not cure the fibrotic part. If fibrotic has occurred, it has occurred, nothing to do with the medical management. You have to go surgery. So ATT will halt the progression of the disease. It will not cause the healing. It can improve the part of the healing. It can improve the speed of healing, but it cannot be healed. It cannot heal the lesion directly. Second, the penetration is various tissue are actually questionable. The penetration means these all drugs of ATT is actually manufactured for lung tissues, not in extrapulmonary tissues. So the question is whether these drugs are actually penetrating inside the tissue or not. This is actually a questionable, but nothing can be done. These drugs are available. Only hardly 12 or 13 drugs are available, including the DRTB. So we have to manage with these drugs only. 99.99% patients actually gets benefit. The tissue penetration, as per my experience, is actually adequate in genital recurrence. So recurrence is actually, patient will ask you कि क्या ये बीमारी मुझे दोबारा होगी, whether I will get this disease again in my lifetime. Definitely, we are not sure whether this disease will come again or no. There's no lifetime immunity for this disease. All the treatment is not surety of the treatment for the long time. There are patients who actually recurred in 2 or 3 years. But most of the time, if patient's not coming back in 2 years, he or she is actually cured from the treatment. So recurrence, we are not sure. Definitely go with the treatment and after the patient's. So these are the drugs which you know well, HRZE for the intensive phase and HRE in the continuation phase. That means isoniazid, rifampicin, pyrazinamide, and ethambutol. So these are the drugs available in FDC for the fixed the combination formulation. How you can give these are the actually weight bands. In I'm talking only about drug sensitive TB. I'm not talking about drug resistance TB because the information will go beyond the scope of this lecture. So these are the weight bands. You can take the screenshot or it is easily available everywhere on Google. So if your patient is suppose 45 kilogram, now this patient has to take 3 tablets simultaneously. Simultaneously, that means ideally these drugs should be given empty stomach, but some patient doesn't tolerate. So give a light breakfast in the morning. And after breakfast, patient take these 3 medications one by one in 15 minutes or 20 minutes or maximum 1 hour. So one by one, actually every 10 or 15 minutes, patient takes tablet one by one with water only. No milk should be given with these drugs because isoniazid absorption hampered with the dairy products. That's why we avoid milk and dairy products around 1 hour prior and after with these drugs. So give these drugs, all medicines in one go because these all drugs mechanism of action is concentration dependent killing. So they have to achieve their maximum plasma concentration in one go. That's why you have to give in simultaneously. Do not give these drugs like morning, evening, morning, afternoon, and evening. Give these drugs in one go only. So how to schedule? Give all drugs in 1 hour max. Empty stomach after food. This is your choice, but ideally empty stomach. If a patient is not tolerating, give light fast, or if it is not tolerating after food, you can also give. There's no harm. Gastritis and hepatitis are the common side effects of these drugs. So what you should do if it is a gastritis, just give some PPI. If it is a hepatitis, ask for LFT to be done. If your SGPT and SGOT are raised, stop all these drugs and refer to some medicine, general medicine people or person or a pulmonologist so that he can manage this hepatitis, drug-induced hepatitis, because this is a very common side effect. Patient comes with severe vomiting in both gastritis and hepatitis. Ask for LFT. If SGPT-OT is raised more than 100, stop all these drugs and send for some physician. And if it's a gastritis, LFT is normal. Just give PPI or even you can give in a twice daily doses. This gastritis will heal off and you can continue with the treatment. Milk, I have already told you. So what to avoid in food? Nothing. Patients ask us, this is a very common question. What should not be taken in food? So the simple answer is anything you can take because this disease is not an allergy. This disease is basically infection. And you can take anything, whatever you want. What is your food habits? You can take anything, nothing to be avoided. Joint pain. Yes, this is also an important adverse drug reaction. Joint pain, people mostly with pyrazinamide. Give some analgesics like anything, whatever you want. Paracetamol, you can also give even diclofenac or ibuprofen. Even you can use tramadol also. So whatever you want to give, just give it. Most of the people get reliefs with analgesic. If it is not, continue with 2 months pyrazinamide. If patient is not having severe joint pain. If it is so severe, send it for some orthopedician or some general physician. They will take care of the joint pain. The duration is very questionable. This is very debatable topic. Wherever I go and take this lecture, everywhere there's a different discussion. Some says 9 months, some says 12 months, some says 6 months is enough, whatever. What government says, at least 6 months. Less than 6 months treatment is not allowed in any kind of tuberculosis. So 6-month treatment is minimum. You can go up to 9 months. Follow up clinically, and if you think the TB has healed, patient is improved, whatever was your clinical diagnosis initially, this is now improved, you can stop the treatment after 6 to 9 months. What is my usual practice is 6 to 9 months treatment is enough for any extrapulmonary TB. So you can stop treatment in 9 months. You can go up to 12 months. This is your choice or your with whatever physician you are treating, your physician's choice. So ATT in pregnancy is entirely safe. Basically, 2 situations we can discuss. ATT started first and then patient become pregnant, and pregnancy started first and then patient then you have to start ATT. In both the scenario, you can continue with the ATT. There's no harm, there's no teratogenic effect of this drug. Only the thing, these drugs actually causes gastritis, severe gastritis sometimes. Patient will vomit a lot, so that have to take care medically. So avoid aminoglycoside, because earlier we used streptomycin. Now streptomycin has been ruled out from this regimen, so aminoglycoside should not be used. Follow up only and only clinical, nothing to do with any investigation. The clinical follow-up is important. If you want something, MRI or USG, you can do whatever you want based on the clinical. So after 6 months, get a repeat sample examined histopathological, bacteriologically. That is only theoretical. I know you will not perform a surgery to just get a sample. So definitely after 6 months, most of the time it's clinical. If you are doing surgery for some other reason, just get a sample and get a repeat CB0 done and examine histologically and bacteriologically. One thing I want to add, CB0, if you perform in a follow-up, it can come positive even after disease has been healed. Why? Because I already told you, CB0 is basically based on what? CB0 is basically based on PCR. So PCR can detect a diet bacilli also. So culture cannot come positive after once the treatment has been completed, but CB0 can come positive for some longer duration. So if you are getting a repeat sample, send it for culture so that you will get the result after 2 months, whether these samples were having live bacteria or not. So what you should not do, rely on tuberculin nigra, already discussed. Inadequate reason, like I already discouraged some private ATTs because the potency is definitely questionable. So inadequate regimen and dots, like just take one drug only because you're not tolerating drugs, this is a wrong thing. Take drug in TDS formulation, morning, evening, night, this is a wrong habit. Take drug like if you are giving a pyruvate ATT, take only rifampicin, take only isoniazid, just take ethambutol and pyrazamide only. These are the wrong formulation. You should not give, just give dots. Inadequate duration, definitely less than 6 month duration, you should not allow. Inadequate schedule, I already discussed. Multiple drug, yeah, this is actually important. Most of the people I see add some multivitamins, some antiemetics, some calcium, many things. Try to decrease the pill burden as maximum as possible for the patient, because these drugs cause gastritis, and other drugs, whatever you add will cause some gastritis. So try to keep minimum drugs as possible so that patient can tolerate well. So what's new in this NTP is IFS prophylaxis. This is only for pulmonary tuberculosis patients. Patients close contacts get the isoniazid for 6 months. This is actually not important for you. And BCG vaccination has started by the program, but it is not in under pipeline only. Soon you will get BCG vaccination for adult also. And this is also a common question I get in every lecture: how to prevent myself or doctors, how a doctor should be prevented from the TB. Just a prayer with the God, because you are exposed with everywhere with the TB. Every patient can have TB, so just pray with the God, you will not get the TB. And second, but what I do in my hospitals, if your stomach is full, you will not get the TB. Eat well, exercise well, you will not get any disease. Forget about the TB. And if you are diabetic, control your diabetes. And if you are any other immunosuppressed status, control your disease so that you will not get TB. Niksha, this is the Niksha platform, what I told you. And this was my next time. Thank you for patience listening. If you are having any questions. Hello.
Hello. Thank you so much, sir, for sharing your insightful and giving this comprehensive lecture on treatment of genital TB. We really appreciate you have taken out time from your busy OPD schedule. We really want to thank you for that. Now we can take the questions.
I have a question. I'm Dr. Abha Majumdar from New
Yes,
Delhi. And very nice lecture. And I'm so glad you made so many things clear. But I would only want to ask you one little thing, that if there is infertility and there is no reason found leading to infertility, tubes are nice, clear, pelvis is clear, she's ovulating, can we ascribe TB to that patient and start giving her ATT and wait till she gets pregnant to stop ATT?
Definitely, ma'am. I actually told in the lecture that if you feel this is TB, this is TB.
No, if you feel, I'm not asking. If there is nothing, there is no infection anywhere, the tubes are patent, the uterus is normal, she's ovulating, and this is a section of infertility which is labeled as unexplained infertility. And sort of infertility specialists, we all have a tendency to say that there's nothing in India which exists as unexplained infertility. So TB is the most common diagnosis given to these women, and they are treated with ATT. Do you think this is the right practice, and we can label patients who are absolutely normal with no clinical suspicion apart from infertility be treated by ATT?
Definitely, ma'am. You can go ahead with the TB because I already told you this is a very common infection which causes actual infertility. This is only the most common infection which causes infertility.
So,
and you're
so
not
you
getting any
feel
diagnosis.
that all unexplained infertility patients should get ATT, which is
Should get
about
ATT.
25% of infertile women
Definitely,
are
ma'am.
unexplained.
Definitely, and you after 6 months you start your IVF procedure and trying for the pregnancy.
Don't
And
you
whenever you
think
get
this
the
will? Don't you think this will bring in drug-resistant TB more commonly? The woman is absolutely asymptomatic. There is no clinical suspicion. She's only infertile. So in the whole world, there is a big section of unexplained infertility. But in India, every unexplained infertility should be treated for TB.
Yes, ma'am. Look, actually, you asked whether will patient get an MDR TB in future or not. Look, actually, if you are giving a complete dots, complete therapy for the patient to the
But she
6 months,
doesn't have any clinical sign. She has no test positive for TB. Maybe a menstrual blood PCR or GNAT, where you say that blood presence should not be there in these two tests. Any menstrual blood will always have blood over there. So we have nothing in that. If there is a PCR positive or GNAT positive, just on that basis, she has no other symptoms. She's ovulating, her tubes are fine, uterus is fine. You recommend that this 25% of infertile women who are absolutely normal should all be given TB treatment.
yes, ma'am. This is my actually strong suspicion. If you have tried everything and you are
No,
getting
what
nothing,
tried everything? I've not tried anything. I've not tried IVF. I've not
ruled
tried
out any other
anything.
cause. If you have
There is
everything
no
in your tool,
cause.
no cause, then you can definitely give. Then definitely give this ATT because there's
Anyways,
no harm in taking ATT. Actually, ma'am, what I
do
want
you
to say,
know how you are?
if there is a yes, ma'am.
You are a TB specialist. You
Yes,
told that all the 4 drugs have to be taken, 3 drugs have to be taken together in the morning, and preferably empty stomach. And you must have seen patients vomiting their lungs out after taking this. It is so difficult to take. These young, healthy girls who sit in a Mercedes and come to our clinic, who have got no exposure to a polluted environment or overcrowding, how can you think that they would have TB as the reason? Where is unexplained infertility in our country? The whole world has unexplained infertility. So why should we give them ATT? Only because they are infertile, we put another curse on them and say, oh, you probably have TB. That's why you're not conceiving. So take ATT. And then, they get hepatitis. You told it's so common. Gastritis is so common. They are vomiting all the while. Do you think it is justified to give these young 28, 30, 32-year-old, absolutely normal girls ATT?
Yes, ma'am. Just let me clear. Ma'am, if you are talking about risk-benefit ratios, there is no risk in giving ATT. Actually,
apart from hepatitis, liver failure, gastritis, and extremely
nothing. These are
uncomfortable
all
6
reversible.
months.
These all side effects are reversible. These all side effects are
Anyways,
actually reversible. If you are talking about a DSTB, whenever you stop the ATT, this
so
hepatitis
why
resolves
can't we do
completely.
this? Why can't we do this that any woman with any symptom, I mean, here the woman has no symptom except that she's not being able to conceive. There could be a woman with menorrhagia, there could be a woman with pain or anything, and we can just give ATT.
If you rule out everything, other infection, if you have ruled out, then you can definitely give.
But
That is
where is the
if you have,
infection? I want to
if there's
ask
no
you.
infection, you can
Yes.
look. If you have nothing to do now, you have to do something. I have seen patients who have nothing in their clinical scenario, we just give ATT. Look, if I talking in my field, patients come with hemoptysis many times, and we found nothing in the X-ray and CT scan.
Right. Hemoptysis
So
is such a
then
big symptom.
some
How
symptom.
can you
So
ignore it?
now if I just if I'm not getting anything in the CT scan, I'm doing bronchoscopy, nothing I am getting, patient still hemoptytic. So I can start ATT there only because the hemoptysis
I
can
agree with
take
you 100%.
so
Hemoptysis is a very important symptom. Here, the woman is not getting
but
pregnant. What
infertility is
has it gone to do?
also important. I think infertility is also the thing. The infertility part is definitely a problematic thing for her. And giving ATT is no harm. What maximum patient will have? Some vomiting only. Whenever you
Some
will start
vomiting.
medicine,
You have seen the vomiting. I have seen the vomiting. I have seen the extent
but
of
vomiting only is
hepatitis.
not the part.
And
Vomiting only is not the
why
part
should
of ATT.
I
But
somehow
definitely,
feel
if patient have the TB, look, ma'am, if patient has the
no,
TB,
she
we will
doesn't have
tolerate it.
TB. She doesn't have TB. She
So,
is
ma'am,
unexplained infertility. She's just infertile.
and if you have taken the biopsy and other things, you have, if you send menstrual culture, send it for culture. If it comes positive after
You
2
just
months,
now told menstrual
though it is
culture
very
has
rare to
blood.
come a culture positive in
So,
menstrual.
so you just now said menstrual culture should not be
Definitely, it is.
taken. There is
So
no
there
other
is
test
actually
which is
clinical. Ma'am,
done.
one thing actually I recommend when I teach opthal peoples. So in ophthalmology, there is nothing to take up for biopsy. This all neurological tissue. You cannot take anything from the eye. So there what I teach, there's nothing in this all slide, only one slide. If you think this is TB, if you find something, whatever it is that thing, start it.
If you find, here we have found nothing. This
So,
girl is
ma'am, this is
absolutely
actually a
normal.
gynecologist call whether they want to start or
Yes,
not.
no, I
From
want to
my
say,
side, as a pulmonologist, if you want to start ATT, is perfectly fine.
so infertility is the function of man and woman both. So we should give ATT to the man also then. Why the woman only?
Tubercular epididymitis, ma'am, actually presents easily. Actually, is presents easily. There's inflammation in the testis and all. So actually, it presents very easily. So most of the
No,
tubercular
I think
epididymitis
infertility is a function of both.
can be easily biopsied also.
Yeah, biopsied, all right. So we must take a biopsy for the man.
Take a biopsy epididymitis. If you having suspecting epididymitis, send for some.
We don't suspect it. It is normal semen analysis. Everything is normal. The female is normal.
Have TB. Semen, you
How?
will not get TB, but
You know,
epididymitis you can
why
have.
I'm insisting on this? Because a very wrong message is going to our infertility specialist. We have been able to reduce the menace of giving ATT by great difficulty in so many years by saying unexplained infertility does not mean that every woman is suffering from TB. TB is only a cause of infertility when it starts affecting the genital tract, the tubes, the pelvis, or the uterus. Now, a pulmonary tuberculosis patient in your OPDs could be standing pregnant over there, and a good advanced pregnancy also. So, TB bacteria in the body do not stop the woman from getting pregnant unless they have affected the genital tract in a way that the sperm and egg cannot meet or the functions don't happen. I just want this wrong message not to go across that unexplained infertility in India means tuberculosis and give the woman ATT. If you give the woman ATT, please allow the man also.
Explain what you do to get to these
Nothing. We do IUI, we do IVF. Unexplained infertility standard treatment is if they have not been able to conceive spontaneously with everything normal.
Abortions, then if patients got
No,
recurrent
that
abortions, then
never mind. Recurrent abortions has its own causes. TB is not the cause of recurrent abortion. I want, as a senior infertility practicing consultant, I have been fighting this menace till in 2012 TB became a notifiable disease. I still spoke to all the infertility specialists. Already these women are cursed ki ye banj hai. Don't add another thing that she is tuberculous, because generally the family says don't let the boy sleep with the girl, isko to TB hai genital. Where is the TB? There is nothing isolated. Tubes are fine. She has no evidence of TB. So don't want this message to go to my colleagues, younger colleagues, that they should start.
Not my call as a pulmonologist.
Yes,
this is not
correct.
my call. This is actually your call.
Yes,
whatever specialty, actually I'm not indulging in your specialty. This is only my part. If you feel, what was my sentence? If you feel this is TB, I'm okay with it.
All
I will
right.
not challenge your diagnosis, whether this is,
So,
because
and you
in my
already
medical
said,
college, actually I'm working in medical college.
right,
So
right,
my department directly start give opinion for starting TB. What
right,
I give in reply, I cannot opine on this thing because I am not
correct,
a specialist in your area. If you think this is TB, I am very much happy to start it.
ready,
And deal with all areas and all.
agreed
So
100%.
this is
So,
actually a household decision whether you want to start or not.
right.
This is your
So,
protocols. Actually, I have launched
I'm very
your
glad you
protocol.
told this, because there is no harm in starting, should not be our statement. If we found no evidence in, and IGRA, Montux are not tests where we can start ATT. Even menstrual blood culture or CBNAT is not a
CBNAT
test
should
where
not be
we can
sent,
start.
yes.
So no other test. And I agree, laparoscopy is gold standard. Whatever specimen you get in the form of culture, fluid, peritoneal fluid, or histopathology, they could be real evidence for tuberculosis. And even if all that is negative, but we clinically suspect over there, there are lesions, there are adhesions, there is caseation, I would 100% agree that I would start ATT.
If there's pathology, this is fine. If it is no pathology, this is now your call, actually.
Okay, right.
Sometimes actually it
So,
happens with me, then neurologists say, yaar, ye TB lag raha hai, to maine kaha, you tell us ki whether this is TB or not. If you tell us
right,
this is TB, I am okay with it. I'll deal with all ADRs and all.
right,
But
right.
this is your call to take it, because I'm not a specialist in your area.
So
If
I'm
you think
glad
this is
I
TB,
brought
it's
this
fine for
question
me.
to you, and I brought it on the forum. So if the patient has nothing, please spare her from ATT, because it is a drug which causes a lot of side effects. Yes, if there is a suspicion of TB, 100% I would give her ATT.
So,
But
okay, so I'm changing
unexplained
my sentence according
infertility,
to ma'am. If you feel this is your TB, this is your call. This is
then,
not my call. So
right,
if you feel this is TB, I'm okay with it. So
right.
whatever your guidelines, follow it as per ma'am. So
Yeah.
I'm changing my sentence. This is not everything is TB, but agar aapko lag raha hai, to just start it. It's fine.
So unexplained infertility in the woman does not qualify her for ATT, the man or the woman, either of them, unless we have something which will say that, yes, there is a suspicion of TB. Thank you very much for the lecture.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you so very much, ma'am, for your insights. Definitely, this thing was also discussed in last two topics, where we discuss it from the gynecological point of view, that we follow the composite reference standard, as also mentioned by Dr. J.B. Sharma, sir.
Yeah.
That if there is some definitive test, or in laparoscopy, we are finding the definitive finding, only then we start.
Yes.
So this is from, and sir was saying from his point of view that if we are suspecting on some clinically, means like on laparoscopy, we are finding the definitive thing, or there are definitive findings on microbiological, histopathological, only then we start the ATT. And
The point is that
unexplained
I will not challenge your
infertility, yes,
diagnosis.
sir.
Only
Yes,
then.
sir. Yes, sir. You
So I'm
both were
very glad,
actually
yeah,
right on your
in their
both
own
were,
way, correct.
yeah, you
You
both
I
were right
just,
write
on
on
your
your
own
OPD
way.
because
Yes,
this is
sir.
TB, I'm fine.
Yes, sir. Because
yeah,
yes, sir. Because like on lapro, we find the findings in accordance with index guidelines. We definitely send reference to chest physician to start the medicine and have the follow up of the patient. So you both were discussing rightly on your
so
behalf.
Ashita,
Yes, ma'am.
lapro, even if your investigations
Yes, ma'am.
show no histopathology
Yes,
or
ma'am.
microbiology is positive, but you have a very strong suspicion of caseation, granuloma,
Yes, ma'am.
adhesions under the liver, which we always associated with chlamydia, but in India it is associated with tuberculosis also.
Yes, ma'am.
This is good enough evidence. If the patient has never taken ATT, we must give her ATT. And
Yes, ma'am.
as Dr. Sharma very clearly told how to take the doses, because most of the young girls who start ATT give it in TDS dose. One
Oh.
morning, one afternoon, one evening. Whereas the
Mhm.
whole drug acts only when all is given together to make
Yes,
blood
ma'am.
levels to be able to fight the bacteria. So lovely lecture. I only
Mhm.
wanted to clarify this because a wrong message
Yes,
would go
ma'am.
around that treat all unexplained ATT
Yes,
women
ma'am.
with ATT. I would say in that case, men should also be treated with ATT
Yes,
because they
ma'am.
have no symptoms.
Yes, ma'am. This was a very
मैंने बोला
important point.
जिसका
Thank
कोई
you
नहीं
for
होता
Thank
उसे
you
taking this
very
CTS
up.
much.
होता है तो हम तो
I
सीखता
was
देते हैं.
very keen to listen to the lecture because it was from a pulmonologist, a TB
Yes.
specialist, because we gynecologists are very poor in understanding tuberculosis and its
Yes, ma'am.
treatment. Thank you very much for this
Thank you, ma'am.
lecture.
Thank you,
Thank
ma'am.
you.
Thank you, ma'am. So we can take other questions in the chat box, sir. Next question is, what's the difference between TB PCR and CBNAT and significance of tests like TB Gold?
Okay, so Dr. Gunjan, actually, first I'll take a simple question. TB Gold. TB Gold is same as IGRA. I have already covered in my lecture that IGRA, Montux, TB Gold, whatever you are getting, just it is not important for your clinical diagnosis because a patient who doesn't have TB can also comes positive. Like people like us who is actually already exposed with the tuberculosis, we will get our TB Gold or Montux positive. Definitely, even Montux will come positive, should come positive. If Montux comes negative, I will think more for immunosuppression. Whether will patient have some kind of malignancy or sarcoidosis or something else, because Montux is coming negative. Why? It cannot happen in India. So TB Gold is actually nothing to do with. Don't rely on TB Gold only. If you are clinically suspecting TB Gold is also positive, yes, definitely it can add to your suspicion, but doesn't make the diagnosis. So don't rely on TB Gold. Second difference between TB PCR and CBNAT. CBNAT is actually a PCR-based test only. So what happens? What is the difference between the CBNAT is a cassette-based test? It's a simple cassette. A simple technician can perform this test. A simple cassette. You just put a sample in it, and the machine will perform all the steps of PCR inside this machine, and just it will give result. Just like a ATM machine, it gives you a slip after 3 hours that this is the result. And what TB-PCR? TB-PCR actually in-lab test. Microbiology people can tell you better how TB-PCR should be performed. But any PCR, not forget TB-PCR, any PCR test needs multiple steps. 4 or 5 steps are involved during the PCR. And this PCR is very cumbersome to perform. And this PCR, a sample can get contaminated between all these steps. So PCR is little bit difficult, little bit lesser sensitive than CBNAT. I'm talking about the conventional PCR, which we do routinely perform for some viral infections also. So this PCR is little bit different because CBNAT is easy to perform, cassette-based test, less chances of contamination. So ask for CBNAT or GeneXpert rather than TB PCR. Things are same, but ask whatever if you are writing on your prescription paper, write it CBNAT or GeneXpert. Don't write TB PCR because it has some different meaning. So write it in a correct term, GeneXpert or CBNAT.
Sir, next question is HPE. This question is from Dr. Shruti. HPE showing granulomas, not caseating granulomas. In endometrial sample, CBNAT was positive. With just granulomas and non-caseating one, we assumed it must be a different organism. Should we go ahead with TB treatment with non-caseating granuloma as well?
Definitely, caseation is not always possible, especially in your endometrium, because you people are actually dealing with endometrium, which is actually shedding regularly. So sometimes time doesn't allow to make a proper granuloma or caseation. Automatically shed off in between the time. So you will not get the proper granuloma, will not get the proper caseation. You wrote here that CBNAT was positive. If CBNAT is positive, nothing to worry about. It's positive, that means positive. You got the bacteria inside the machine. So that machine has detected this bacteria. Now you can go ahead with the treatment. This is confirmed diagnosis. CBNAT positive treatment means 200% confirmed diagnosis. You can go ahead with the treatment. And with granuloma, caseating, non-caseating, depends on your clinical. 90% granulomas are TB in India, basically. So give prior treatment.
So thank you for clearing the doubt, sir. But then there were 2 cases, sir. One case, the CBNAT was positive. Like both had only non-caseating granulomas. It wasn't that proper caseating granulomas of TB. One case, CBNAT was positive. The other case, CBNAT was not positive. Since both the cases were a little consecutive, we did TB culture for that case, and that turned out to be positive. But then CBNAT was negative. TB culture was positive, and it was a non-caseating granuloma. It was just granulomas.
That can occur. That can occur. Actually, it depends on your whether from where you have taken the sample, how much your pathologist is equipped, means he are experienced with the caseation, because sometimes caseation is so small, somebody cannot detect it. And sometimes caseation become fibrosed, so you cannot get the caseation and the thing. So caseation is specific. It's not sensitive. Basically, if you're getting a caseation, definitely it can add it to your confidence. But if it's not getting caseation, don't think this is not TB. Granuloma alone can give you this difference. Look, how granuloma forms actually? Granuloma forms after some chronic infection, especially infections which are intracellular. Because this bacteria actually go inside the macrophage, macrophage lysosome complex, and stay in the cells. So now the other macrophages comes and these eat that cell and becomes a granuloma, becomes a epithelioid cell, Langhans type of cell, giant cells. So many terms we can use for this thing. So these all the things depends on the which stage the disease is basically, and from where you have taken the sample. So only the caseation definitely it can add to your confidence, but sometimes you will not find granuloma even. You will just find some chronic inflammatory cell. That chronic inflammatory cell, lymphocytic predominant, you can also see that this is some chronic infection. You can go ahead with TB if you are having some clinical things also. Most of the time, actually, TB heals with fibrosis. TB is a chronic infection. It heals with fibrosis. Wherever, not in uterus, lungs, spine, brain, abdomen, everywhere. Wherever TB bacteria stays, it heals with the fibrosis because macrophages become fibroblast after some time, and you will get fibroblast in your tissues. So if you are getting fibrosis, now the chances of having TB is more. So this is all depends on the stage and you have wherever you have taken the biopsy.
Okay, sir. Thank you very much. Thank you.
Okay, Shruti. Dr. Prithi was asking something. Frozen pelvis, no evidence of endometriosis, bilateral hydrosalpingo and these are very technical terms. I'm not used to with these terms. Endometrial ball, no vascularity, should be start ATTL. Ma'am, can you please clear your questions, Dr. Pratibha? Please, if you can open your mic.
Dr. Pratibha, you have asked if there is frozen pelvis and there is no evidence of endometriosis and bilateral hydrosalpingo is there. And unexplained infertility, endometrium is bald. I'm taking it as endometrium is pale.
Yes, ma'am. It is
And there is
in the
no
vaccine.
vascularity. Yeah, then as we have already discussed in the last class by Dr. Rana, he has told the hysteroscopy and laparoscopic findings, which corresponds to the diagnosis of genital TB. We know that it's a paucibacillary disease. So there are high chances that your reports are going to be negative. But like the findings you have said, on the basis of this, on these laparohisto findings, we can start ATT.
Yes, ma'am, because most of the time the reports we get negative.
Yeah, they will be negative. Yeah, it's a paucibacillary disease. So we have definitive findings on histolaparoscopy. Last time, Dr. Rana has also discussed his paper. It is available, and all those findings he has very nicely explained in that paper. You can also go through that, and you can give the reference of 2018 Index TB guidelines, and can take reference from papers from Dr. J.V. Sharma sir also. Yeah.
I hope, Dr. Pratibha, you are clear. Actually, I'm not getting your question. This is beyond my knowledge. So
I think, sir, that's all. There are no other questions.
Okay.
Thank you so very much, sir.
Thank you very much.
Thank you, sir. Thank you so very much. I think we can stop the class now. Thank you.
Okay.